Welcome to the Research Day, Religious Engagement and the COVID Response, hosted by the Centre for Religion and Public Life at the University of Leeds. The present panel focuses on the theme Religious Communities and Pastoral Care in Times of COVID. Our first presenter is Dr. Jo Sadgrove, who works for the Anglican Mission Agency, USPG, and also is a visiting fellow in the Leeds Centre for Religion and Public Life. She will be presenting today about pastoral care across space and time, some early observations. Welcome, Jo. The floor is yours.
Brilliant. Thank you, Adrian, and good afternoon, everybody. It's very nice to be here. Can we go to the next slide, please, Adrian? So the COVID-19 pandemic intersected with the beginnings of an AHRC-funded project on pastoral care in the early modern British Atlantic, for which I was working as an impact partner in my role in an Anglican mission agency, now known as USPG. As an Anglican mission agency with early modern origins, founded in 1701, USPG occupies a rather strange position, facing both the UK and the churches of the Anglican Communion, but belonging to neither. The quest for identity and role for a liminal organisation like USPG has been an ongoing challenge. Working historically has helped to think in different ways about what it is as an organisation and what its core mandate might be, particularly in a situation of global crisis. This collaboration with Dr. Alison Searle, based in the School of English at the University of Leeds, involves the trans-historical exploration of pastoral care provision beyond the state. Next slide, please, Adrian. An online exhibition makes a very small number of key manuscripts and printed documents from the first 20 years of the Society's history accessible, and contextualises this archival material through a focus on pastoral care and transatlantic communication via the technology of the letter. In dialogue with USPG's early archive, and we're looking at 1701 to 1720, the project team became engaged in what was, in the context of COVID-19, a strikingly relevant conversation informed by the excavation of forms of pastoral care in the early modern organisation. Next slide, please. The archives comprise hundreds of letters between the bureaucratic centre in London and missionaries often isolated, anxious and uncertain in the colonies of Britain's emerging empire. These letters, which are themselves technologies for extending pastoral care, detail the challenges and queries of a group of people negotiating identity and care across distances, and they raise fundamental questions which USPG as an organisation is still navigating. These include, how do liminal communities extend caregiving? How do the practices of care embodied by historical religious communities speak to current thinking about the provision of aid and the role of faith actors in the global public sphere? Key questions being worked out in the archival material resonate in striking ways with the COVID era. How do we extend remote care? Who is the object of care? How do local care needs define what the church is in any place? How does the church understand and minister to the diverse range of contexts and needs of new congregations and communities? How is care resourced? These research questions were explored with Church of England clergy and chaplains through a survey, interviews and participant observation at social care and hospital chaplaincy meetings. Most significantly for this paper, they were also explored through a series of webinars facilitated by USPG as part of its own engagement with its supporters and global partners. I'm going to talk about the webinars in the context of the archival engagement and in relation to USPG's African partners before returning to the UK context and what these data suggest. Next slide, please. COVID-19 has transformed the media through which relational capital is extended and by which a global community can be brought into dialogue. In 2020, a series of online webinars was initiated by USPG to engage UK-based supporters, donors and volunteers who would normally attend several face-to-face regional and national conferences.
What I want to talk about a little bit this afternoon is some of the work we've been doing, really gaining some primary data on chaplains' experiences across MHA, and I will give some specific and sort of more individual output from that as well. But just to say, before I took on this role with MHA, which does stand for Methodist, it actually stands for Methodist Homes for the Aged. I don't know why we don't use the aged word so much. It's such a popular term in the 21st century. But we are an organisation, for those who don't know us, that is now substantially separate, although founded by the Methodist Church in 1943. We have a minimal connection in terms of the operation of the organisation. It is a separate entity from the church. However, because of our foundation and the legacy of that, we do employ chaplains, and we're the largest employer of chaplains outside the public sector. So we have 140 whole-time chaplains, probably about 60 whole-time equivalent. And there is also a support structure. So there's myself as a director, there are 2 heads of chaplaincy, North and South full-time, and some part-time support and advisory roles as well. So that just gives you a little bit, perhaps, a flavour of the landscape. And I came to this having done 16 years actually at the Leeds Teaching Hospitals, and 4 years ago I left to take up this appointment. But it's relevant. I just want to start really talking about that in terms of the experience of the pandemic where I am now. In those 16 years that I was in Leeds, there was on one occasion a major incident. And it occurred about noon on a Friday, and it was a minibus accident on the M62, which caused the emergency services to trigger the major incident protocols with the setting up of Gold Command, Silver Command, and so on. And that fortunately, due to the circumstances of the event, it actually really only lasted about 5 hours. A&E actually had to manage doctors turning up it couldn't use because they were coming in on their day off or their off shift because they caught it on the news, and they kind of needed to find space to put to these supernumerary doctors who then didn't all turn out to be needed. So it was a highly managed event really that lasted just a few hours, although quite moving. Before I went over to the Leeds General Infirmary where this was being managed, I was at St James's and on the top floor visiting a patient, and it's the only time I've seen air ambulances stacked waiting to land. So there were moments within that short emergency that were poignant and significant, and obviously for those caught up, and sadly there was one loss of life of somebody involved. But otherwise people were tended to, and surgery and whatever else was required took place. 5 hours. And then of course last year COVID began, and the organisation where I am now adopted a similar gold, silver, bronze command system to manage what was occurring and unfolding. And of course the dashboard that gathers that information is still running at over 400 days or wherever we are now. I lose track myself, and the Gold Command has stepped down at times, but of course for Wave 2 stepped back into action. So it has been, as a colleague I work with in the NHS says, a chronic emergency. Quite a different event compared with the short, sharp major incident where lots of neighbouring authorities provided help and assistance and so on, to then be caught up in an overwhelming event where in fact there isn't a healthy bit, as it were, of the sector to be able to send that support. So pressure on staffing, particularly bank and agency and so on, as the pandemic unfolded. As we came into the pandemic and began to get a little bit, I think, more to grips with it, it occurred to me that experience was flowing, and it was obviously a dynamic and rapidly changing experience, particularly in the early days. Chaplains on the whole, because they were fortunately employed and were part of the staffing, attended their care homes or retirement living schemes. But only at that point, at the start of the pandemic, did I discover, because why else would I have known, that 20% of our chaplains were aged over 70. So they immediately went into the shielding category. So we didn't have chaplains everywhere. And at some point, probably in early to mid-May 2020, I felt we needed to do something to capture some of the experience of what was taking place. And so fortunately, we had an intern funded by the Methodist Church and called Hope, and Hope agreed to undertake some in-depth interviews with chaplains who were willing to speak to somebody. So at the end of May, she conducted 6 interviews with chaplains in different situations, some who were shielding, one in particular, I think, who really did feel completely disempowered and unable to help, one who was supporting at a distance, and some chaplains who are actually in homes, and in some cases in homes that have been quite badly affected. So we began to get from that some emergent insights, and I'll come to one specific example, but I thought so important was the data, the interview material, the qualitative interviews, and Joe, by the way, was helping us with this. Thank you very much, Joe, in supporting Hope doing these interviews, that we thought there was merit repeating these on a quarterly basis to the completion of 1 year. So we now have 23 interviews. One was missed on one occasion, an interview was missed, but otherwise we have, as it were, the full set from May 2020 to March 2021. As well as some ancillary information. Joe, I think as she mentioned there, was involved with us in a research event in which also chaplains at MHA participated, and that information was also with consent recorded and preserved. So what does it tell us, and where does it lead us to reflect theologically? This is one transcript, and it's simply an overview of some of the themes and topics. So 4 interviews are quarterly occurrences beginning in May, and Hope, in analysing these, giving some brief analysis, decided to choose a word as to the overriding theme that occurred while these interviews were taking place. So for this one chaplain, over those 4 interviews, they began with duty, disbelief, frustration, and finally change and reflection. Recurring themes across the interviews included trauma. The concept for this person was referred to in every interview. Trying to get to grips with what was happening, questioning whether she was experiencing a form of PTSD, post-traumatic stress disorder. Just to say as a matter of detail about that, just to perhaps help understanding if there's an issue, is at times we were facing what I would describe as mortality rates akin to intensive care in an acute hospital. But you have to remember, normally our residents are with us on average 2.5 years, 2 to 2.5 years. So this sudden transition into a context of very high mortality for our staff, who will spend a lot of time with people, getting to know them, was particularly traumatic. Often, including chaplains, will know relatives, will know other people associated with the resident, visitors from the community, and so on. One of our homes, due to the particular nature of where it was and the situation, the local authority insisted they went into scrubs. So they were actually wearing scrubs for almost a year in a care home, as well as wearing all the other associated PPE, such as a mask. And this is just such an alien experience for the care sector, compared particularly with the NHS, which does have a little more experience of this. That was trauma. Realisation of grief. So carrying the sense of bereavement and the awareness, and the sort of, there's a study on intensive care nurses that refers to them as disenfranchised mourners. And I think, given the separations during the pandemic of relatives unable to visit, perhaps because they were shielding themselves at end of life, not necessarily that we weren't able to facilitate that, but I think there are a lot of disenfranchised mourners at the moment, of people who would have gone to a funeral or a memorial or been with somebody at the end of life who haven't been. Pastoral support, unsurprisingly, that featured a lot, but a sort of pivot really more towards staff, or a changing balance of time spent with staff rather than with residents. Not that residents were neglected, but in some cases there were fewer residents, unfortunately, due to the circumstance of the pandemic. Guilt. Guilt occurred as a word because services were not being taken, religious services were not being taken, people weren't able to join in those. And as a chaplain in this particular context, that was to be something that would be normal, and it was absent. And this particular chaplain talks about going to every resident's room due to the guilt that she'd missed people dying. And this was less apparent in later interviews, but in the earlier interviews, obviously the chaplain hadn't been able to be there on every occasion that somebody was dying, and they felt guilty about that. Anxiety. Sometimes the family was concerned about the chaplain attending the care home because what may have been brought back, etc. Privilege, because of the position, the opportunity to be there, perhaps when relatives couldn't be, and at least to try and offer some kind of support. Within two feelings finally linked to two organisations. One, the NHS, was a shift perhaps from at the beginning thinking that care homes were having it a lot worse than the NHS, and also that social care was underappreciated, but maturing or changing to a belief that nobody's experience is worse than anybody else's. And lastly, persistent and recurrent frustration at government. That gives you a little, sorry to take the time with that, and I haven't got too much more to say, but gives you a little bit of an oversight of one of what will then be a set of six summaries really of the experiences people have had providing that care. I think from, it's really important for chaplains to be able to voice that and to reflect it more widely, because care homes can be hidden little worlds in themselves, and they've been even more hidden during the pandemic than they normally would be. In terms of some growing or developing theological reflection about that, I think there's some very interesting work by John Swinton around lament that I think we need to take seriously to address that issue of disenfranchised mourning and grief that has failed or not had opportunity to be expressed. And I think there are rich seams of biblical and liturgical ways in which creatively that can be recognised when the opportunity of people being safely together again emerges. And the other area of theology which I've found helpful in terms of my own thinking and response has been trauma theology, and in particular Shelley Rambo's title on that. And just to finish with one of the things that she says, because it's really it's set in the context of those of you who may not know it, in the aftermath of the Hurricane Katrina in New Orleans. And again, it's hard to compare this experience with previous overwhelming events that have been more localized, but they do perhaps offer us some insight. And she recalls at the beginning of that, where I think she was a volunteer attending and with a group of volunteers, and when they were inducted, having arrived in New Orleans, the person from a local church who was doing that said that as things had begun to improve and the storm had passed and so on, there was from central government and some other places a sense of, well, it's finished now, it's happened, pull up your bootstraps, get on with it, life's back to normal. And this person who was doing the briefing said, the storm has gone, but the after the storm is always with us. And I think that, how we emerge out of this and our insight into the experiences people have had, I think will hopefully inform that as to how we facilitate some kind of spiritual recovery and give opportunity for things that have been lost and denied during the pandemic.
Yes, this is a project I'm working on with my colleagues here at the University of Zurich at the Professorship of Spiritual Care, and relates to a research we've been doing on digitalization in spiritual care. And of course, as we know, the pandemic has been a massive catalyst for digitalization in many places, and so it has been the case as well in spiritual care. So we've been conducting interviews, over a dozen now, with different people working chaplains and spiritual care providers, mainly in the US, using digital technologies in this work, and who began doing so very often during the pandemic. So I myself, I'm a medical anthropologist. So I'm not a chaplain myself, but I work closely with chaplains. So maybe for those of you who are not familiar with spiritual care and the work of chaplains, so media narratives of the pandemic very often focus on the political aspects of the pandemic. So, the origin of the virus, resistance to the control measures, the vaccines, epidemiological developments, treatments, lack of medical infrastructure, all the things that we have heard today as well. But very rarely in media discourse we hear about what happens what happens with the existential fears of people who are in intensive care and those who are dying of COVID-19, because it is also very difficult to speak about this and listen to the spiritual suffering of patients who are affected by it. And so in most hospitals in Europe and America, there is a special job. This job is given to the hospital chaplain and spiritual caregivers. And they usually are invisible, but they perform a very important function. And arguably, they are the only profession in modern hospitals whose work is exclusively dedicated to caring very deeply for the whole person and in the full depth of his or her existential pain. And so, of course, it became very important during the pandemic as well. Now, of course, chaplains were barred very often from direct contact with chaplains. And this is where another development in healthcare was taken on or utilized, and this is that of telehealth. Now, I'd like to briefly introduce as well what is telehealth, because it's also not familiar to a lot of people. So a lot of people think of, maybe Adrian, you can show the first slide there. People think of remote controlled surgery, as you can see in the first picture there. Another rapidly developing application is that patients can leave hospitals very soon. They don't even have to stay sometimes for after controls, and they can be kept in their homes as long as possible, where they can be monitored using sensors which automatically communicate with the hospital and with the doctors there, and see their doctors via video call and manage patient files, see their test results, and all these kind of things. So particularly for chronically ill and elderly and palliative care, this is very promising, and in some leading health systems in the United States is really being rapidly adopted. One reason for that, of course, is people don't have to travel to the hospital, and there are also huge cost savings associated with it. Now, during the pandemic, there was another enormous benefit which became obvious, which is, of course, the patients can receive medical care and also spiritual care without risking infection. And chaplains can continue to work even if they are not allowed to enter the room of a patient, or in some cases are not allowed to enter the hospital at all, and only essential stuff. So now that the pandemic, in Europe and America has largely peaked, many health institutions have gained a new appreciation for this telehealth, and has grown absolutely rapidly. So several thousands in percent if you look at the private medical insurance reimbursements. So a massive increase. And spiritual care providers have realized that if they want to maintain their role, their function in the hospital, they have to be part of this development. And so they must develop a digital presence. And so the answer which is emerging now is this kind of odd term of Tele-Chaplaincy. Now, Tele-Chaplaincy is not just the use of Zoom or Skype to speak the way we do now, but it is actually an integration, ideally, of spiritual caregivers into a comprehensive telehealth software solution, so that they become part of a virtual hospital, which is really being built in many places. And so if you, Adrian, could go to the next slide. Thank you. I'd like to very briefly, and another click to show the first picture. So I'd like to just briefly show you 3 pictures to illustrate how the presence of spiritual caregivers has changed so far. And so you get an appreciation of what the implications are of this move into telehealth. So the first picture there is one of many pre-modern depictions of a priest in the house of a sick person. The priest knows the family or knew the family often, sometimes visited them, conducted a census as well in some countries, and, knew them maybe from church, might know their confessions, and, often these pictures show the ritual of the anointing of the sick. And it is interesting that this is, in the home of the patient. So if we can have another click, please, Adrian. So this is a spiritual caregiver, a chaplain, a Jewish chaplain, as he has been produced in the 20th century institution of the hospital. Usually fulfills a non-confessional roles, and so he is a Jew, but he provides the service to people of all faiths. The encounter is typically limited to the visit of the patient in the hospital, where medical rationalities, of course, dominate. And increasingly, he is part of an interdisciplinary care team. And so he makes notes in the electronic medical records, he partakes in team meetings, and he's become a professional ministering to a universal, a spirituality recognized to be universal and not just to his own confession. So if we can have another click, please, Adrian. Now we see a development which actually started before the pandemic in 2018. So this is an employee of Mercy Virtual in the United States, massive health systems founded by a Catholic sister in the mid-19th century, is operating over 250 healthcare systems. He himself is a Pentecostal Christian, and he works as a Tele-Chaplain at Mercy. So James accompanies patients in the Mercy Health networks from when they are admitted to often after they have been discharged. So he uses the Mercy internal telehealth software, and of course during the pandemic this was already established, all this infrastructure, to evaluate the need for spiritual care, to stay in contact with the care team, to document these interactions with patients, and of course to talk with patients even if they are in quarantine, right? This is easily possible through this technology. Now, through his integration in this institution-wide telehealth infrastructure, the spiritual caregiver can actually develop often a new kind of deeper, longer-term relationship with the patient, because he meets the patient in his own home via video call. If a patient, say, is in quarantine, or he is an outpatient and sent home for monitoring, he can stay in touch with the chaplain. So he's not just meeting the chaplain while he's in the hospital, so he can stay in touch through video call. And of course, his family might be in his home, so the grandchildren might come and sit on the knee of the patient and meet the chaplain in this way, and he might give them a tour of where he's living, so the chaplain gets to know the life of this patient in a way which it wouldn't have been possible before. And so particularly during advanced care planning, these kind of meetings are a very different experience when they are not conducted inside the hospital where everyone wants to leave as soon as possible, as feasible. So the pandemic actually, often there is a narrative that, it was a compromise in a lot of ways, and spiritual caregivers, lost a lot of depth and presence. But what we're finding is some cases where this actually hasn't been the case at all, this narrative. So where it has opened up a new vista, so to speak. Now, if we could have the next slide, Adrian. Now, the COVID pandemic has forced a lot of spiritual caregivers to adopt to this way of interacting with patients. And over the past year, this model of 20th century place-based spiritual care has been shown to be just one way of doing this very important frontline spiritual care labor. And, you know, it's still too early to say much about the specifics of this development, especially in Europe. Telehealth is in its infancy, and Tele-Chaplaincy was usually limited to just Zoom calls or, you know, video call software. And the US, this development, telehealth, is much further advanced, and there are several major hospital networks where spiritual caregivers have been fully integrated into telehealth. And of course, during the pandemic, this took a major leap. And a lot of people, a lot of chaplains are now understanding that there's an opportunity as well, which can actually enrich their work and don't want to go back. So the pandemic has not only kickstarted the deployment of telehealth in many institutions, but it has also shown that many spiritual caregivers that this development might be a chance to infuse their work with a new life. And in some ways, returning to a more traditional role of the priest who knows the family over longer term, which wasn't possible, you know, when spiritual care moved into this place-based, clinical, hospital-based spiritual care. You know, was much more harder to do in that context. Now I'm conscious that I have a couple more minutes, so I'd like to just make a few more points on this. One thing is that there needs to be more clinical evidence to show that outcomes for patients are receiving telechaplaincy are in fact similar to in-person chaplaincy. And there also is a big need for best practices appropriate for this technology. And very delighted that, you know, the valuable work of Sally and WHO has been making huge leaps towards guiding faith communities to create best practices. So there is a need for best practices as well in tele-chaplaincy. And some chaplains are already looking at this. And there's also still some questions which are unanswered. So one is the legal limitations of telehealth. So in the past year in the US, it has not been easy for health institutions to provide services across locations, especially outside of state borders. During the pandemic, this emergency regulations softened this a little bit. And if this is enshrined in law in the coming years, this will give another massive boost to telehealth, and in this way also how spiritual care is delivered in hospitals. Another major challenge is that of demand, because when a chaplain visits the patient in a hospital, this often creates and reinforces demand in the way that, you know, he might knock at a door, you know, get a feel for the patient, see what needs he has, and maybe even by coincidence, you know, meet his family. This is much more difficult through telechaplaincy because it is often on appointment or demand, and so there are fewer possibilities for chaplains to spontaneously meet and in the shared space of the hospital, right? However, at the same time, a lot of healthcare chaplains report getting more referrals from specialists for the care of outpatients. And some institutions have integrated chaplains so closely into the workflows that the transition to telechaplaincy didn't impact patient demand. And finally, of course, not everyone has access to Wi-Fi and smartphones, so the digital divide is a problem, particularly in rural populations. And large health systems, like the Department of Veteran Affairs in the US, have developed programs to bridge that gap in the provision of telehealth. And this, of course, can also benefit chaplains who can now reach out to people who might be in a very rural place and never be able to talk to the hospital chaplain about, you know, their suffering. So yes, now that this pandemic is, you know, increasingly managed in some places, at least in Europe and America, you know, it is time to engage with this trend, I think, and explore how we can ensure that patients continue to have their spiritual needs met in the medical institutions, which are really emerging and I think we will become a norm in the near future. So this I wanted to share today on this topic, and looking forward to